given size is where we start thinking about doing a biopsy. A centimeter, obviously, is maybe the first knuckle on your finger, for those not familiar with that term. So in any case, so about 5% of cancer, most of them are benign. We follow them sonographically with sonograms if we biopsied it and everything turns out to be benign. Sometimes nodules can cause another problem. They can produce too much thyroid hormone. And in those cases, patients become hyperthyroid because of that nodule. And those patients we can control the same way we control the other patients with some medication and plus or minus surgery. Okay. So what does a slow thyroid look like? A hypothyroidism, right? A slow thyroid, again, and there's a theme here, antibodies. We talked about the fast thyroid being caused by antibodies, and here's another situation where a slow thyroid is being caused by antibodies. The antibodies are binding to the thyroid gland, again, causing an inflammatory response of the thyroid gland, and then killing the cells of the thyroid gland. When that happens, the thyroid begins to slow. This is called Hashimoto's disease, right? The fast thyroid is called Graves' disease. This one is called Hashimoto's disease. So when the thyroid gland slows, you take Synthroid going forward for the rest of your life, right? Now, how would you know you have a thyroid problem? What symptoms would you be complaining of? Well, symptoms would be lack of energy, getting very cold all the time, developing coarse or thin hair, getting constipated, right? And the thing about all of those symptoms, you look at them and you say, well, that kind of sounds like me. Well, that definitely sounds like me. And for me, the thin hair, it definitely is me. But the idea is that not everybody that has those symptoms has the disease. So it's important to not only tell your doctor or tell your provider about your symptom and say, but it's important to actually have the test to see if you have that particular clinical condition. And the great part of it is it's pretty easy to test for in the blood. So, as I said, you take your thyroid hormone. It's fortunately not like insulin. Insulin is an injectable medicine. This is a hormone that we can take by mouth, so it's much, much easier for our patients to take. What's very important with thyroid medicine, and I know some of you are my patients and take this medication, it's important to take that pill on an empty stomach 30 minutes before you eat or drink anything else. If you're taking calcium, it's important to separate that pill by 4 hours, right? Do not take the pill at the same time as your calcium because you will not absorb the pill and you won't get the clinical and biochemical benefit in your blood. Okay, so many folks that have thyroid disease happen to be young ladies, right? And one of the things that they come in and they're panicking about is, can I get pregnant if I have this condition? And the answer is absolutely. But there are things that we need to do prior to pregnancy so that we optimize your chances for having and sustaining a pregnancy. We have to check the blood work before pregnancy, ideally, and if the dose needs to be adjusted, at that point, it would be important to adjust that prior to conception. Because if you have a thyroid that's out of control when you're pregnant, it can cause two problems. One, it can increase your risk for miscarriage, which is a difficult thing for patients. And secondly, the baby's intellectual development depends upon having the proper amount of circulating thyroid hormone. So consequently, if you have this problem, it's important to speak to the doctor and make sure your levels are perfect prior to conception. Are there any natural remedies, right, for thyroid disease? The answer is there are not. People ask me all the time, doctor, is there a special diet that I should use for my thyroid? The answer to that question is no. Now, not to say you shouldn't have a healthy diet, right? I want everyone to have a healthy diet. And what is a healthy diet? I want people to be eating tons of vegetables. I want them to be eating lots of protein, whether it's plant protein or lean meats, right? And I want them restricting their carbohydrates. So my advice to my thyroid patient will be the same advice I would give to my diabetic patient. It's the same advice I would give the patient seeing me for fatty liver or high triglycerides, all of those things. High vegetables, tons of vegetables, lots of protein and carbohydrate restriction. So is that going to help your thyroid? Probably not, but it will help every other part of you. So it'll prevent you from getting diabetes, it'll prevent you from getting blood pressure, it'll prevent you from getting overweight, right? So all of all of those conditions would be treatable by the same thing, but I can't say the particular diet with respect to the thyroid will be helpful or harmful. One of the things that's out there relative to the thyroid is iodine. And there's lots of conflicting data on iodine. Some people, if you look on the internet, tell you to take iodine. Some people to say to avoid iodine. And the question is, well, what should you do? And the answer is, we don't, generally speaking, have iodine deficiency in this country. Why is that? Why don't we have iodine deficiency? Because if you look when you buy salt, I'm sure most people have bought salt in their lives, and you can see that it's iodized salt, right? The government has sort of pushed the salt companies to put iodine in the salt, so that we don't develop iodine deficiency and develop thyroid problems, right? Now, they do sell non-iodized salt, but they kind of hide it. You have to look on the bottom because they don't want you buying it. They want you to buy the traditional regular salt that has iodine in it, so that we do not develop thyroid problems relative to iodine deficiency. So putting this all together. So this is a complaint I have all the time. Doctor, I'm tired. Does that mean I have a slow thyroid gland? Now, it does not mean you have a slow thyroid gland. You could have a slow thyroid gland, but it doesn't mean that you have one. So the way to figure that out, though, is to check. And it would be important to ask your doctor, please, doctor, check my thyroid gland because I feel like something is off. But if you're talking about fatigue, let's talk about things that can be causing fatigue. Well, one of the biggest things people tell me all the time is, they tell me, doctor, I'm tired. I say, well, how do you sleep? And they say, well, I don't sleep at all. So I tell them always, I said, well, you cannot have energy if you don't sleep. So that's step number one. So it does not necessarily mean you have a thyroid disorder. But also, a big thing that people have in their lives is stress. Right? Stress is the killer of us all, right? I mean, and we have stress we have financial stress, right? We have stress from our work, stress from our family, stress from our siblings and kids and all of these things in life. And this builds up and it causes people to be very tired. So if that's part of your problem, it's important to address those things and deal with that stress in a healthier way. Working too much. I think my wife would agree that I do that, and that certainly counts for when I'm tired. There are other things, depression, anxiety, other medical illnesses, fibromyalgia, too much alcohol consumption. And one thing that I think is often overlooked sometimes is medications, right? When you have a few medical problems, doctor has you on 3, 4, 5. I mean, I have patients on 20 medications sometimes. And when they have those problems and they have these symptoms, it's certainly possible that sometimes medications are the cause. So it's important to discuss not only your symptom, but also could your medicines be contributing to some of the way you feel. And in those cases, stuff like that. So, I get this one all the time too. Doctor, I'm overweight. Does that mean my thyroid is too slow? And the answer is, well, maybe it's too slow. But look at this guy over here. What's he eating? Drinking. Coke. And God knows what that is over there. So the point is, yeah, your thyroid might be slow, but it might not be. And you have to think about whether or not our food choices are optimal and the physical activity is appropriate. And one of the things that I think comes up a lot with my patients in particular is, you get a little bit older, and of course our metabolic rate does slow with age. And one of the things that comes up a lot is, doctor, my knees hurt, and I can't exercise like you want me to exercise. As I understand that. But the trouble with those orthopedic issues is what happens when things hurt to do things. What do? You do fewer things. You avoid going with your family to a long trip or to Disney World or wherever you might go because you know what? It's too much walking, you tell yourself. There are small things you do every day. Oh, you want to do something in the kitchen, but you know what? I don't want this knee to hurt again. I'll do it later when I'm up. And those small things add up over the course of the day, course of your life. And they cause you to retain calories, not burn calories, and you gain weight over the long term. So the trick is, if you've got a solvable problem, if you've got that foot surgery you've been putting off, or maybe the doctor told you really need to have your knee replaced, that will help your weight, and that'll help everything else when you're more active, when you're more physically active. So it's important to think about weight not only as food and output, but what are your barriers to exercise? What are your barriers to movement? And sometimes orthopedic issues can be a big problem. So what other medical reasons are there to be overweight? Well, something called Cushing's disease. Cushing's is when your adrenal makes too much of a hormone called cortisol, and that can be checked with a few approaches. One is with a 24-hour urine collection that your doctor can check for you. Some people that have heart failure, they actually retain a lot of water, or liver failure, they retain excess water. There's overeating and physical activity, which we discussed. For food choices, of course. God knows this holiday season has been tough on a lot of my patients, including myself. So it's important that we, now that the holiday season is over, we get back to making our better food choices. And the other thing is some medications can cause weight gain. And I also treat people for diabetes, and I give people 2 classes of drugs, something called the TZDs, or sulfonylureas, and these are 2, or insulin even, and those are 3 actually classes of drugs that actually cause weight gain, right? So it's important not only to look at your medication list for the efficacy, but also the side effect profile. And of course, people are on steroids for a variety of reasons, for their lungs and such. Those can also cause weight gain. So the long and the short of this is, the thyroid can cause weight gain, but does that mean your thyroid is too slow because you can't lose weight? The answer to that question is no, although it's possible. This is another one. I feel nervous and jittery all the time. Does that mean my thyroid is too fast? The answer is, well, it's possible, and as I mentioned before, but there are a lot of other illnesses that can cause you to feel this way. One is anxiety, right? Another is another hormonal problem of the adrenal gland called Pheochromocytoma, when your adrenal gland would make too much of a hormone called adrenaline. So if you make too much adrenaline, it can make you feel jittery, nervous, and shaky. So that's another thing that your doctor might want to take a look at when you're complaining of these symptoms. Some medications can do that, or stopping medications abruptly can also do that. Also caffeine, right? Having too much caffeine can make you feel jittery and anxious. I had a patient the other day for diabetes, and he was telling me, doctor, is coffee okay for me to drink? Right? I said, sure. I mean, if as long as you're not, getting the coffees where you're putting like whipped cream and all this other stuff. I said, well, that's fine. He said, well, how much is okay? I was like, well, how much do you drink? And he's like, I drink 15 cups a day. I said, well, that is a little bit too much. I said, so I mean, if it was 1 or 2, I would have said okay. But so I guess the point is that everything is in moderation. But so too much caffeine is also no good. Illegal drugs also, for obvious reasons, can cause you to be jittery and nervous. So the bottom line of all this, if you're having symptoms of either a fast thyroid or a slow thyroid gland, it's important to tell your doctor. The answer is as simple as a blood test. So we'll check your blood, we'll see what the problem is. If you've got a thyroid problem, then we can treat it. If you don't have a thyroid problem, then you've got to move on to another thing, because literally something is causing your symptoms, so we've got to do a little digging sometimes and find out what it happens to be. So general health tips: always go to the doctor with questions about your health, and always take your prescribed medications as indicated on the bottle. If you feel like something's wrong after starting your medicine, including for thyroid medication, it's important to let us know, because we can make adjustments as needed based on your clinical situation. So here we do have a great thyroid team. And the thyroid team consists of a group of really special people that really work together for the patient's benefit. And who does it start with? Well, it starts with having a good internist. And the internist will sit with you and they'll talk to you about whatever medical problems you have, and they certainly will go over your symptoms with you and screen you for a thyroid problem. Many times, if they identify a thyroid problem, then they will refer you to someone like me, who's an endocrinologist. And we diagnose and treat thyroid disease. But sometimes you need imaging of your thyroid gland. And then you get the radiologist, right? So the radiologist will do an ultrasound, take a look, and the radiologist will interpret that scan for us to ascertain whether there's any problems with the thyroid tissue, including those nodules that we talked about a little while ago. And then sometimes we've got to do a biopsy. I do them, every day in my office. We'll have the patient lay down, we put a needle in the neck. Very, very simple procedure. The needle gauge is the same needle gauge as when you have your blood drawn. So it's a very simple procedure. There's no prep work. You don't have to fast. You don't have to stop your blood thinners. It's a very, very simple procedure, office procedure. And then I send that specimen off to the pathologist. The pathologist is the doctor that specializes in looking at the cells of the body and determining if the findings are cancerous or not. And so if they want it to be cancer, then you would go to a surgeon. The surgeon would remove the thyroid gland. And then we work with nuclear medicine doctors. Nuclear medicine doctors give patients that need it radioactive iodine. And radioactive iodine is radioactivity that will kill thyroid cancer if it happens to go other places in the body. And finally, we work with a medical oncology team, and those patients will give rarer cases or more advanced thyroid cancer patients chemotherapy. Very, very rarely do we get to use chemotherapy in thyroid cancer, although when you're dealing with a practice like mine that we see a ton of thyroid and thyroid issues, we do use medical oncologists to help us administer chemotherapy. But the idea is this is a team, right? I can't do a good job if I don't have colleagues working with me to have, having a good team to work with. If I don't have the surgeon, I've had the surgeons call me up in the operating room and tell me, doctor, these are the findings. What do you think about what I'm planning to do? And literally, we'll make a decision on the spot like that because things change sometimes when you go in the operating room, right? And I've had the pathologist call me. I've had the radiologist call me and say, what do you think? What's going on? And these people contact me directly in the middle of looking at or doing their case because they know that I want, for my patients, the best outcomes, and that results when people are actually talking and communicating with one another. And I think that is the scope of the presentation. Do you guys have questions? We'll start.
Okay.
Yeah.
Is there a hereditary component in thyroid?
Yes, there's a strong hereditary component to this. It's estimated about 10% of the population has, especially women, have hypothyroidism, and about 1% of women have hyperthyroidism or fast thyroid. And you can see this generation to generation in patients. And almost always, when I have a thyroid patient, I will ask them, do you have a family history? Anybody in your family, especially first-degree relatives, anybody has thyroid disease, or not only thyroid disease, but also a history of autoimmune conditions? And what are autoimmune conditions? Type 1 diabetes, rheumatoid arthritis, lupus, Sjogren's syndrome. These are all conditions that are associated with thyroid disease. And yes, there is a strong hereditary.
First of all, I'm a patient of Dr. Otterbeck's.
Yeah.
Again, the picture does no justice for you. Really.
More handsome in person, right?
No, you should wear glasses. What do you do for a sluggish thyroid?
So for sluggish thyroid, what you do is you would give thyroid hormone, and which would be Synthroid is the brand name, or levothyroxine, which is the generic name. And we would increase the dose as clinically indicated by the levels and the patient's symptoms. So we increase, and then we make sure that the levels are within range. Once you get the levels within range, and then you've got to determine, does the patient still have symptoms? And the answer to that question is yes. We have to make sure there's not other things going on. One of the things that mimics thyroid disease a lot is, and I always ask patients this when they complain about persistent symptoms, is sleep apnea. One of the things that people complain of with their thyroid is, I'm tired, I can't lose weight. Very common, almost all the time. And what I ask them is, do you snore at night? And many patients will say yes. And I say, okay, so in that case, we have to look into other problems that could be causing some of your symptoms, and that would be one of them. There's a whole host of others, but and of course you do that with blood work and different tests, but that just commonly is one of the things that comes up in practice.
And this is the medication that they have to take the rest of your life?
Thyroid medicine, well, with a slow thyroid, it is forever. With a fast thyroid, and I remember a little while ago, I gave you those 3 approaches to thyroid patients. You could either give radioactive iodine or surgery or thyroid drugs that slow down the medication. Most of us prefer, or many of us prefer, to give the thyroid medications that slow down the thyroid when it's a fast thyroid, because a good number of those patients, depending on the study you read, 30 to 50% of patients actually can go into remission and actually come off those thyroid medications. But if it's Synthroid for a slow thyroid, you need it for the rest of your life, For a fast thyroid, you could theoretically can't come off medications because you can go into remission.
So what happens when you have the just in between? You know, you're not here and you're not there.
Well, then you're normal, hopefully. So if you're not fast, you're not slow, hopefully you're normal. We can talk about the specifics, after, but yeah. Glenn?
I was just going to ask, if you are not undiagnosed patient,
Yeah.
becomes pregnant, female becomes pregnant,
Yes.
what do you do? If they weren't, they need a thyroid medication, where do you go from there?
So you're talking about hypothyroid, right?
Correct.
Yeah. So if you're hypothyroid and you get pregnant, well, it's important to go to your doctor immediately, whether it's your primary doctor or your endocrinologist or your gynecologist, and they have to do blood work immediately. And you've got to know what dose you're on, so that when they get the blood work back, there's a normal range, right, on the lab. For pregnancy, the normal range is different, and we particularly for a measurement we call TSH for pregnancy, that's got to be less than 2.5 for pregnancy. So we measure, particularly in the beginning, we measure the thyroid hormone monthly for women who are pregnant, because it's so essential for them, not only for them sustaining the pregnancy, but also for the development of the child. So if you develop a thyroid problem during pregnancy, which does happen, you would just go on the medication once it's identified. But what's interesting is that most of the societies don't recommend checking, the gynecologic societies. So the problem is not all women are screened for thyroid disease, so you can miss some, because there really is no strong recommendation for professional societies to screen everyone. Right? What else, guys? Yes?
How old you can get a thyroid? Young age?
Mhm.
Or which age?
It's a good question.
What is the question?
And yes, so the question is, what age can you get a thyroid problem? And you can get a thyroid problem at age 0 when you're born, right? In fact, every child born in this state is checked at birth for a thyroid problem, because if you don't have a thyroid, some people are born without a thyroid, that we really no other way to identify it. So every child at birth is checked for hypothyroidism. And there are infants, 1 or 2 days old, that develop this problem, and they have to take thyroid medicine their whole life. What happened, and of course I'm an adult physician, right? So I'm seeing adults, but kids in their 10, 11, 12 can develop hypothyroidism, and most of my patients are developing it anywhere from their teens all the way up to their 90s, right? So yes.
But nobody knows the thyroid 30, 40 years ago. So how do we know if it was born or not?
Well, probably 30 and 40 years ago they did know, but you're right. To your point, there's a time when they didn't know, and there really weren't tests for this. And then you see the folks with those big goiters on physical exam, right? But there were all sorts of diseases really that people just died of, right? What did we do? For instance, with patients, type 1 diabetes, right? Type 1 diabetes was a disease. Well, it's a disease where patients need insulin to live. And what did we do years ago for those patients when we didn't have insulin? Not too long ago. It was a certain death, right? It was nothing to do with those patients, for those patients. Terrible. But now, thank God, we have effective, safe treatments for them, which is insulin. So yeah, there were people that died of thyroid disease all the time because we didn't have a modality and approach to treatment of those people. And the thing is, we might not even know what they died of. We just knew that they were dying. The doctor would come and see them, and I think everybody in this audience is too young to remember probably, but like house calls, right? The doctor would come and see the patient, and there was nothing really they could do for those patients, sadly, and they would just pass away. They would say, okay, they're dying, right? So the idea is, we've advanced, thankfully, and now we have appropriate treatments. But there were plenty of people that just felt terrible. Maybe they had enough thyroid hormone to keep them alive, right? But they just felt miserable because they didn't have enough. And that's what we're trying to do. We're trying to figure out who needs treatment and who doesn't, and make them feel their best, right? Both from a biochemical standpoint, the blood work, and from the clinical standpoint, how they feel.
I'm coming from Italy. My family is there. Sometimes I want to know the history.
Yeah.
But nobody knows.
Yeah, a lot of people.
I have a thyroid. I ask a question.
Yeah.
I don't know.
Yeah.
Some people they don't even know what a thyroid is.
Yeah, some people don't like to share their health information and with their family, and I'm not sure why that is. Privacy, or they just don't want people knowing their business, whatever. I usually think it's a very poor idea not to tell people what you've got, because it helps them, right? It helps them to know what a family history is, and not only for thyroid disease, but also for heart disease and diabetes and cholesterol and all these things.
Cancer.
Cancer, right? So all of these things are important. If we don't share the information,
Exactly.
You know,
Nobody knows.
no, right? So it's unfortunate when that happens.
Because when you go to the doctor, they want to know the history.
They want to know.
I don't have no history.
Yeah.
How do I gotta find out?
I know. It's a challenge. But
Thank
now you have your own children, right? So at least you have your history you can give to them, and they can share their history with you.
The
Yeah.
information to the next generation,
Yes.
my family.
Yes.
But my husband and I, we struggle to find out.
What's the
So
story?
nobody knows the family.
You're right. Yes.
Is thyroglobulin count and no symptoms.
Yeah.
How frequently you have to check the patient?
So your question is if you have elevated thyroglobulin antibodies, and how often should you check the patient? Well, the answer is when they're symptomatic. So the answer to the question is really whenever. So when I have patients like that, I tell them, look, I'm going to see you every 6 months, and I'm going to screen you every 6 months for deterioration in your thyroid function, because I know your thyroid is going to be slow. You're not there yet, but it's going to be slow. But if you ever feel X, Y, or Z symptoms, call me. Now, the problem with that approach is that patients have a lot of these symptoms anyway. They feel tired, they feel constipated. But I tell them, you know, you've been you your whole life. You know when something is not yourself. And if that's the case, here's a lab slip. Go for labs. You don't even need to call me. Go for the labs, and then I'll call you and I'll let you know what the story is. So I always say every 6 months or as needed. Yep.
What food contains iodine other than salt?
Salt is really the main source of iodine in our diet. So there are a lot of other foods that have it, but it's really minuscule. And that's why it's been so important for them to put it into the salt, because because we need it. And furthermore, I mean, multivitamins can have salt. I mean, can have iodine in them. But really, dietary sources of iodine have very, very small amounts, and certainly not enough to sustain what we need.
Because if you want high blood pressure, you have to watch it.
Yes, exactly.
That's exactly right. That's exactly right. But the amount that you need is not much. So and that's the point. Because we heavily put the iodine in, all you need is a little bit of salt in your diet, and not much at all. And listen, anybody that eats out anywhere ever, you get enough salt because I pour the salt on, so you'll get enough. Yes. Oh, yeah. I'm sorry.
I have a rather unusual thyroid problem.
Yes.
At age 44, an endocrinologist found the problem, and I had half my thyroid removed.
Yes.
And I took Synthroid for 30 years.
Yes.
60 milligrams and then 88 milligrams.
Yep.
She was retiring in June. I went to see her one more time.
Yeah.
And she said, there's a problem. I want you to go to Boston. I want you to go up to Sloan Kettering.
Yep.
And see Dr. Wong.
Yep.
Actually, it wasn't Dr. Wong, it was someone else. He wasn't ill.
Yep.
I said, why after 30 years would I have a problem? I've never had a problem. They told me I have to wait till next year, but I'm very worried about it.
Well, so I mean, I probably we could probably handle it one-on-one together. You and I can talk about it individually, but
I would like to
But-
get to see.
yeah. But the question is, did you develop cancer? Did you develop, did the thyroid become slow? Without the labs, it's very hard for me to give you advice. But we'll talk after, and we'll hook up.
It's a very strange thing.
Yeah,
30
we'll talk.
years later. Thank you.
Yep.
I believe that one of the side effects of levothyroxine
Yes.
is a bone thinning over a period of time.
Yes.
So what do you do in that case if you have osteoporosis?
So this is actually a great question. And this is one of the challenges of prescribing medications, because they give you that thing at the pharmacy which lists a million things of how the medicine can kill you, right? And if you read it, you say, "Oh my God, was this guy crazy giving me this medicine?" No. So the medication thing, the insert talks about osteoporosis and thyroid medication, and that is true if you're overtreated. So meaning, if we're giving you too much thyroid hormone, so say you need 50 and we're giving you 100, and we're giving you those symptoms, palpitations and anxiety and tremors and all of that, that causes increased bone turnover, right? And causes thinning of the bones and osteoporosis. But if you're taking the medicine and the levels are normal and they're consistently normal, there is no reason to believe that the medicine should cause osteoporosis. So if the circulating hormone levels are correct, then this doesn't cause osteoporosis. But if you're being overtreated, then yes, it can cause osteoporosis. Good questions. All good questions. Yes.
Can you take Synthroid
Yes.
with antidepressants and vitamin D?
You can take them in the same person, but not at the same time. So meaning, a person can be on antidepressants and Synthroid and vitamin D, but they cannot take them at once, the same moment. The reason being is because those other medicines will obstruct the absorption of the pill. Synthroid or levothyroxine, which is the generic name, needs to be taken once a day, every day on an empty stomach, because the other medicines will interfere with the absorption of the pill. Now, I have some patients that tell me, doctor, I have been taking it this way for 30 years and my number is perfect. I usually tell those patients, well, don't mess with perfection. So if you're taking it that way, you're absorbing the right amount, then fine. But generally speaking, taking the medicine concomitantly with something else, it will prevent the absorption of that pill. Mm-hmm. Yes.
Thyroid cancer.
Yes.
I understand it's prevalent on the island.
Yes.
What are the statistics as compared to the city, and how treatable is thyroid cancer?
Yeah. So actually, Advanced did an article on this issue about almost 2 or 3 months ago. I don't know if you had seen it. We do have a much higher rate of thyroid cancer relative to New York City, and in particular relative to our colleagues or friends in Brooklyn and Manhattan. And the reasons for that aren't entirely clear. Is it environmental? God knows. I mean, we had the dump for a while. We had these winds that people hypothesized from New Jersey. I don't have an answer to that question. I know that what I do know is that people in Staten Island, thankfully, go to the doctor a lot. And when you go to the doctor examines you. And when you go to the doctor and he examines you and feels something, sends you for a test. And then he finds something. So we don't know whether or not it's a truly higher prevalence of this disease in Staten Island relative to other places. We do know that the numbers are there to support higher numbers of patients, but we don't know if they're being screened systematically the same way. We don't know the level of care they're getting in other boroughs. So it could be that we have more doctoring going on here relative to other places. And if you don't look for something in life, you don't find it. So I'm happy to say, many of the colleagues I work with, the primary care docs, all these people do a great job with their patients. They're looking for stuff. And when you look for stuff, you find stuff. And that may account for some of it. Whether there's an environmental cause or something else, nobody knows the answer to that question. What else, guys? Yes?
Unfortunately, Dr. is getting the lecture, but
Yes.
when is the time that you do a biopsy on the thyroid?
So
When does it
yeah.
get to that point?
Absolutely. So the thyroid can develop those bumps that we talked about, nodules. And when you have the nodule, that's the thing that you would consider to biopsy because that's the piece of this that could be cancer. Now, the question is, are they cancer or not? And we determine that based, especially on the size.
The doctor
Examines you, feels the neck, or you go to the doctor for something else. And one of the big ways that I find, or people find a lot of thyroid nodules, is that they go to the doctor, they complain of dizziness. This is a classic patient. They complain of dizziness. One of the things that doctors do sometimes is they do a carotid ultrasound or a carotid duplex to look at the blood flow to the brain. When they do that test, the doctor sees, oh my goodness, there's some thyroid nodules on there. And then they send you for a dedicated study of that test. So it's either by being incidentally found because you're having another test, or because the doctor felt something and they sent you for the test to look at the thyroid tissue. But anyway, when they're above a centimeter, that's when we start thinking about doing a biopsy for patients.
You don't routinely do that.
There is no recommendation to routinely check a thyroid ultrasound to see if a patient has a thyroid nodule, despite the fact that some studies show 2 out of 3 people in the world have it.
Which,
Thank you.
Yes.
excuse me.
Yeah.
Which salt do you recommend, the sea salt or regular salt for thyroid?
Well, so I would recommend any salt that's got iodine. So my understanding is sometimes with sea salt, they don't have iodine inside of it. So I would recommend regular salt. Having said that, please restrict your salt. Don't go crazy with salt. I don't want everybody going into their doctor. Dr. Otterbeck told me to have lots of salt and the blood pressure is like 160 over 100. Please don't do that.
I don't have to worry about it because my tendency is the
Low blood pressure.
When I went to the doctor, they said, oh no, you gotta eat a lot of salt to start being, they however, a lot of salt, because of my blood pressure was
On the low
very
side.
low.
Yeah.
But then I got swallowed full.
Yes. Don't go too much with the salt. Somebody over here. Yes.
I heard, and I don't know if there's anything to it, so I'm asking, the difference between synthroid and levothyroxine.
Yes.
I know levothyroxine is the generic, but I heard that levothyroxine is definitely not as effective as synthroid, but I don't know.
So the FDA, when you make a generic drug, the FDA explicitly allows a difference in the potency of the drug, right? You can't make, try to make an apple pie, right? You don't make it have exactly the same twice, right? It's always a little bit different. So when the generic companies make a formula, it's not exactly the same as the brand, say Synthroid, which is the brand that you're talking about. So it's never going to be exactly the same. So my philosophy with it is if you're on the brand, I leave you, if you're doing well with it. If you're on the generic and you're doing beautifully on it, I leave you on it. But if there's a question of whether in an individual patient the potency is fluctuating or the numbers are fluctuating and the patient is taking their medicine consistently, those are the patients, generally speaking, where I would push them to try the brand. I have a general philosophy in life of not to fix things that aren't broken. So if things work well for a patient, fine. But the point is, if you're struggling, that's the situation where I would push you to definitely try the brand to see if it makes any difference. Yeah.
I take thyroid, have for like 20 years.
Yes.
I noticed you didn't talk about that at all.
So Thyroid is an interesting drug. Thyroid is it's actually what we used prior to having thyroid hormone in Synthroid or levothyroxine. Thyroid is desiccated pig thyroid. So what they do is they take pig thyroids and they put it in a pill. And it is an effective treatment. It is approved to be used there. It's not standard. And what we do generally with Thyroid, most people what we use is the levothyroxine. We give patients what they call T4, which is the main hormone that the thyroid makes. So if the thyroids aren't working well, we replace what they're not making it with T4. We let the body convert what it needs to the other hormone that you need, which is T3. When you take Thyroid, it goes around that process. It gives you both T4 and T3. So there are some patients that will say, I feel better with Thyroid, which has both T4 and T3 in it. It's important, like any other treatment that you would use for the thyroid, to make sure the levels are good. Because if we're over or under treating the patient, they're not going to feel good. They're going to get all the symptoms of hypo and hyperthyroidism. So I certainly don't object to patients taking it. Certainly they want to try it and somehow they feel better with it. It's fine with me, so long as we're getting our levels to where they need to be and I'm not giving you symptoms of too little or too much hormone. What else? One more? Yep.
I have what they call the neuropathy.
Neuropathy?
Yeah.
Yes.
Does the thyroid have anything to do with that?
Not typically. Neuropathy can be caused by diabetes. It can be caused by vitamin deficiencies. It can be caused by a few other things. So, but not generally speaking would neuropathy be caused by this unless your level will really, really out of whack. But yeah.
What numbers do you look for?
Numbers for the thyroid.
Yeah.
So we're looking at the circulating hormones of thyroid hormone. So the three main blood tests that are checked. Well, there's thyroid antibodies, which can tell you whether you have Graves' disease or Hashimoto's disease. That's one type of antibodies. And there are other measurements of thyroid hormone. One is TSH, one is T4, and another one is T3. Like we were talking about with the armor thyroid, T3 is the hormone that is in armor. T4 is the one that is in synthroid levothyroxine, and then the TSH is a global assessment, the most important value with respect to how we monitor and measure people's treatment and screening for them and treating their thyroid disease.
That's when I gave the blood work to the TR office. They said they have to look at the numbers.
Yep.
So how do you know when the numbers? They'll tell you. Is this really such a thing as numbers, or?
So the numbers, what I think what they probably meant was that the hormone levels, as they relate to the normal ranges, that's probably what they meant. So when they say the numbers are normal, that what they're saying, I think, is that the levels are falling within the normal range. So that would be a good thing.
But what are numbers?
They're the levels, the actual hormone levels in the blood. So when we say the numbers are normal, that means we've measured the circulating levels of the hormone, and those are within the range. We'll talk about it. What else, guys? Anything else? No? Well, it's a pleasure to see all of you.
Well done.
Yes.
Well done.
Yeah. Oh, thank you.
Well done. Thank you.